Hi, everyone. Welcome. Thanks for joining the North American chapter webinar. We're talking about GLP-1s and surgery and cardiovascular risk, and we have a great lineup for us. But first, I'd like to introduce you to Samer Matar, who is the current president of the North American chapter. As all of you know, he's also a past president of ASMBS. He's a dear friend and colleague, and he's also a full professor at Baylor School of Medicine.
Thank you, Marina. Good morning, everybody. Yes, we do indeed have a star lineup of speakers today. We're going to discuss a very relevant topic that we're all, that there's a big interest in. And I'm very excited about this session. I'm Samer Matar, as Marina mentioned, and Dr. Kurian here is well known to everyone. She's a professor of clinical surgery at NYU Langone. She's a past president of ASMBS and, of course, in the leadership of IFSO, and is a world authority on all matters obesity and bariatric surgery. We have Dr. Vani Potluri as one of our prime speakers today. She's an assistant professor of medicine at Baylor College of Medicine, where she received her MD in internal medicine training. She now practices outpatient preventive medicine at Baylor McNair Internal Medicine Clinic, with rare stints at Ben Taub General Hospital on the teaching service. Her interests include metabolic syndrome and weight-related complications, and she is certified with the American Board of Obesity Medicine. Dr. Potluri, should we go straight into, or do you want to, or Marina, do you want to?
I want to introduce Ali and
Yes,
also
please.
Lydia Alexander, who's going to be joining us. So actually, Ali Aminian is going to talk about the surgical aspect, and he's well known to everyone. He's professor of surgery and director of Bariatric and Metabolic Institute at Cleveland Clinic. In addition, just as my own shout out, as always, to Ali, he's such an incredible researcher. You cannot give a talk without actually finding one of his articles and having to include it. Not having to in a bad way, but I mean, you must. It's a must to include because the data is so amazing. So I'm looking forward to his presentation. And then at the end, after both presentations, we're all going to be discussing what they've presented and get some real world findings and perspectives. And to join us to do that is Dr. Lydia Alexander, who is the Chief Medical Officer for Inara Health, Fellow and Diplomate of the American Board of Obesity Medicine. She is the current president of the Obesity Medicine Association, and we look forward to having her discuss with us as well.
And to all our viewers, please, if you have any questions or any comments, please put them in the chat. And of course, we will be canvassing and responding to every question we can. So without further ado, Dr. Potluri, please start with your presentation. Thank you so much.
Thank you so much for having me. So let's go ahead and jump right in. So can everyone see my slides okay?
Yes.
Perfect. So we're just going to be talking a little bit about GLP-1s. You know, this is like, you know, a hot topic in medicine. So many of our patients come to us requesting these medications, and they have a lot of benefits. But we're all going to talk also a balanced approach, a little bit about different organs they work on and also side effects as well. But let's jump right in and talk about the most important topic, which is going to be their relationship with cardiovascular risk reduction. So no disclosures. I think everyone knows that the prevalence of obesity and the incidence of obesity, and it's that it's an epidemic, is like very well known to the population that we're kind of talking to in clinic, but also to us. Like, it's very notable, and it's just getting worse. And we know that obesity unfortunately impacts every organ system, and we're going to focus on a few of these, particularly cardiovascular implications. But these patients oftentimes are complex, comorbid, and they really, really need help. And by working on their weight, we can have dramatic improvements in their health. Now, I think more and more over the past several years, we have seen that obesity is a brain-gut axis issue. So the pathophysiology is very complicated. It's not just what goes in and comes out. It really is a very complex interplay that starts in the brain and is very heavily influenced by the gut. And we know that we need to work on this from kind of a very comprehensive approach that targets both the brain and the gut. And a lot of our interventions that are successful work in both pathways. And so I think it's really important. I love to talk about POMC-CART, but it is one of the major targets for all weight loss medications that we have available, GLPs included. So there are a lot of medications. Like, I'm not going to go into great detail about this, but I think it's important to kind of know that there is an ascending order in terms of how strong these medications are, with absolute risk weight reduction at 1 year. So the oldest medications, things like Ally that are now over the counter, do not work centrally. They don't work on the GLP-1 receptor. They don't work on POMC-CART and the central pathways, and they don't tend to be as effective. The newer agents, they do work centrally as well, but you'll see that depending on how much implications they have in the POMC-CART pathway, they might not be as effective. And so I just like to kind of point this out. Of course, the most popular guys on the block are going to be the GLP-1 receptor agonists and also the dual incretins. And so kind of going to jump into why that's so important, because the percent of body fat loss or body weight loss is very, very important in putting people into remission when they have metabolic syndrome. So at as little as 3%, we do see improvements in triglyceride and glycemia. And with further reductions in our weight to 5%, we start to see blood pressure benefits. We start to see improvements in hepatic steatosis. We start to see improvements with further reduction with sleep apnea, which is why we have new indications for some of our dual incretins for sleep apnea treatment. And but it's at the 15% mark that we start to see this CV risk reduction really starting to have benefits, and we start to be able to do things like put diabetes into remission. And it's important to note that before the advent of GLP-1s, especially the newer GLP-1s and the dual incretins, we haven't been able to reach this 15% with medications alone. And so it has been very important to have newer agents that are able to get to these higher levels of percent body weight loss or body fat loss. So, it's really important that maybe the two major comorbidities, of uncontrolled obesity and metabolic syndrome tend to be diabetes and cardiovascular disease, and those go hand in hand. And so it is important, to focus on the medications that are going to work on these areas. And so we're going to talk mostly about GLP-1s because they're most efficacious in these populations. So let's kind of do a quick kind of dive through the different articles that we have, and then kind of what we've seen with over the past decade with these classes of medications. So we do have excellent studies, meta-analyses that show that basically GLP-1 receptor agonists can reduce all-cause mortality, but most notably cardiovascular mortality in our patients who have type 2 diabetes. So a lot of the initial studies were, of course, done in the FDA-approved population, which is type 2 diabetes. And we do see that, with the initial studies that you have up to 9% reduction in hospital admissions for heart failure as well. Now, with subsequent studies, we're seeing even more data about MACE, and so the tirzepatide studies and SURPASS-4 are obviously showing that there is a lot of benefits, and there's definitely non-inferiority when we're comparing to glargine or insulin or other populations or treatments for type 2 diabetes. Now, subsequent studies have shown, like the SELECT trials, have shown that we have a marked reduction in MACE and those who are on these medications for, so we're basically in diabetic populations and diabetes at the highest dose, especially with and in weight loss populations with the highest dose of Wegovy or semaglutide, we are seeing that there is a 20% risk reduction of MACE in these populations. And so there is a lot of benefits for our cardiovascular patients. It is important to note that with these come benefits in other kind of modalities. We're seeing benefits in renal event reduction benefits, and also long-term CKD risk. And so it's really important that we kind of focus on how these medications can help our patients who've previously kind of suffered from complications of diabetes and weight, with mostly cardiovascular complications and death. And so, excellent data in this situation. It is important to kind of talk about pathophysiology as well. How do these medications help our patients who have, eventual cardiovascular death and non-fatal and fatal MIs and strokes? And we're thinking that the pathophysiology is very complex, and we're going to kind of go through this in a couple of future slides. But obviously, we see improvement with weight loss alone. But these medications also kind of, they work in blood vessels, and we have seen vasodilation, we see changes in heart rate, we see a lot of other parameters that are changed. We see cholesterol reduction, we see reduction in inflammatory markers. And so all of these, in addition to, of course, glycemic control, are helping reduce our patients' cardiovascular morbidity and mortality. So it is also important to notice that note that we have marked heart failure benefits with these medications as well. And the mechanism might have to do a lot with maybe increase in cardiovascular, kind of increase in heart rates, also increase in maybe outflow, like, cardiac output. But it is important to note that in patients who have tachyarrhythmias, patients who have LV dysfunction, we have to be very careful about those implications of having a higher heart rate. On average, sometimes we see an increase of even 10 to even sometimes as high as 20 points in their heart rate. And this is kind of like a class effect, but we're seeing it more in the stronger agents. And so patients will complain about having palpitations. Some people are completely asymptomatic, but in patients who are prone to tachyarrhythmias or who have struggled with already high baseline heart rates, this is something that you have to kind of take into account. And so I really love this figure because it kind of shows how GLP-1s work in so many different areas, and those can have subsequent downstream effects on weight and metabolic syndrome. So in this, of course, we know GLP-1s work in the pancreas, and they can help with glycemic control. They can increase insulin release. It is really important to note that this insulin release is glycemic dependent, or sugar dependent. So basically, if the blood sugar is high, you are going to see reduction in production of insulin and reduction in the sugars. We usually do not, with GLPs alone, see any signs of hypoglycemia. So you're not going to be falling below normal levels. And so these are actually ideal agents for patients who are high risk for hypoglycemic complications. These are patients with frailty, patients who are older. I mean, the flip side is, of course, some of those patients cannot afford to lose weight. And so it is important to kind of choose the right agent based on the person's predispositions and underlying risk factors and medical conditions. We also do see that, again, the blood pressure benefits. So we do see reduction in blood pressure. It is important to note that some of this is weight mediated. Sometimes it can be the agent itself. But sometimes there is the offset. Sometimes if we see increased heart rate, cardiac output, sometimes we do see some ups, some downs. And so we have to monitor blood pressure very closely. And as we lose weight, as the blood pressure comes down, it is important to note that several people have sometimes come in with hypotension. They were previously on multiple agents and now no longer need as many agents. And so people on GLP-1s really need close follow-up to avoid iatrogenic complications. We want to make sure we don't have hypotension, falls, and injuries from that. The central actions of these medications definitely decrease appetite through pump-C-cart pathway, and so this can lead to metabolic changes. People will report that maybe initially they're not making large changes in their diet, although lifestyle and diet is always a baseline on which we build all anti-obesity medications or weight loss medications and even diabetes medications. We do see that people will report they're having weight loss that they previously weren't able to accomplish with their current lifestyle. And that is because the changes in the metabolism that come from POMC cart sometimes can maybe increase metabolic rate. And we also see very clear reduction in the size of adipocytes, and this can, again, lead to fat loss. Sometimes this is usually a very positive thing, but sometimes the loss of adipocytes in certain areas has led to, certain cosmetic concerns, and that is not something that we can control in this situation. Now, let's talk a little bit about the gut implications, because, the GLP-1 effects in the gut are sometimes unintended, and sometimes the largest issues we see in this population. We have delayed gastric emptying, so these medications are not contraindicated fully, but they're very, not a great idea in patients who have underlying gastroparetic issues. And it is very much to be expected that in patients who have underlying gut dysfunction or motility dysfunction will have complications. And so someone who has severe gastroparesis, you absolutely do not want to consider these class of medications or consider them with extreme caution, because there is a high chance that they'll be hospitalized with complications from gastroparesis, given the additional delays in gut emptying. We also see other benefits like decrease in chylomicron secretion, but most people, we warn about nausea, vomiting, and any kind of lower gut symptoms, diarrhea or constipation. A lot of people at the higher doses seem to be more predisposed to the constipation, but that is not always the case for everyone who has constipation. There are definitely a few that suffer from a lot of diarrhea. With the weight loss, and then also because of how these medications work in the gut and the hepatobiliary system, we also do see an increased risk for gallstones and gallbladder disorders. So you have to be very, very careful, because, as we know, other risks of GLP-1s include pancreatitis. This is a warning on these medications, and gallstones don't help that situation. They definitely will increase the risk of pancreatitis. So you might have multiple different modes, either direct pancreatic toxicity or gallstones that might increase the risk for patient morbidity and on these medications. And so just a lot of benefits, but also a lot of potential for side effects. And we have to counsel our patients aggressively about this so that they're aware of how these medications are working and what they might see while they're on these medications. Now, I also love this figure because it kind of shows how we have so many different organ systems. Not all of the organ systems that the GLP-1s work on are listed here, but these are the organ systems that are most relevant in the setting of cardiovascular or cardioprotection, risk reduction, and also for side effects. So we talk a little bit about the central effect in someone who already has very poor appetite, very poor intake, who this will further reduce their appetite. And so that's usually a good thing in most of our populations, because we're usually dealing with obesity and elevated BMI. But we have to keep in mind that these patients, when they do consume something, have to consume something with high protein, make sure they are maintaining their nourishment and their the vitamins. And so it's really important that we counsel them aggressively on eating properly with these medications. We also see with the reduction in weight and the adipocytes, and through kind of the metabolic changes, we see a lot of hepatic and liver benefits, especially if we have sufficient weight reduction or fat reduction. We do see remission of in several trials of MASLD and MASH. We haven't demonstrated, any large trials, any fibrosis benefits, but we're seeing we can stop MASH or metabolic dysfunction associated steatohepatitis, previously known as NASH, in its tracks, and prevent further damage to the liver. And this is really important, since now metabolic dysfunction associated liver diseases is now the #1 reason for transplantation in women, and the top 3 for men. And so it's a very, very large cause of liver morbidity and mortality. We know that these medications also have a lot of renal benefits. We're going to talk a little bit about this. They are not as renal protective as the SGLT2 inhibitors, but they are noted to have decrease in albuminuria, so they can help with diabetic nephropathy and reduction in CKD progression as well. And we already talked about blood vessel implications. It is also important to notice that there are early changes that with the decrease in inflammation, there might be an improvement in plaque stability as well in these patients, which is probably driving a lot of the cardioprotection that we're seeing in these patients. And then also in the setting of heart failure, we have a lot of inflammatory benefits that might help with mitigating long-term heart failure hospitalizations and complications, which we're seeing in the studies that we discussed already. So it is important to kind of keep in mind that the benefits from a cardiometabolic standpoint are present in both those who have obesity and those in the setting of diabetes and non-diabetic populations. And so we see a lot of benefits with weight alone, but we're seeing blood pressure benefits, as we kind of harped on multiple times, but we also see a lot of cholesterol benefits as well. Obviously, they're not going to be maybe on par with statins, but they're one additional factor that is really helping stabilize our patients from a cardiometabolic standpoint and reducing their risk for cardiovascular complications. We talked about this kind of briefly, but basically when we look at the studies, we are seeing that GLP-1 receptor agonists have a lot of benefit in the setting of type 2 diabetes for CKD prevention and diabetic nephropathy. Not as much as SGLT2 inhibitors, but they are an excellent second-line agent for that benefit, and oftentimes first line for all the other benefits. And so we oftentimes use them both together for kind of twice as much benefit. It is important to notice, sorry, before I flip forward, it is important to note that actually the newer GLP-1s are the ones that have this benefit. The older exendin 4 analogs, this is going to be exenatide and liraglutide, actually, we're not going to see these benefits. And so this is really going to be with semaglutide and ardoinicretine tirzepatide. So just something to keep in mind if we're looking for renal benefits there. And then it is important to note that these medications, because of how quickly they reduce the A1C when they're initiated, we do see an increased risk for retinal bleeds and retinopathy getting worse. You have like a relative, your eyes are used to all the sugar when the sugars are uncontrolled, and then you suddenly reduce available glucose, and you have all these new vessels that are very leaky and suddenly are not getting fed, and so there is a risk for bleeding. And so I usually ask any patient who has uncontrolled diabetes or even controlled diabetes to see their ophthalmologist to make sure there is no uncontrolled diabetic retinopathy, because we want to laser those guys down. We want to intervene on the retinopathy before we do a large-scale reduction in their A1C and accidentally trigger some other kind of problem, which is again, very few of these studies look into the long-term implications, which is that by preventing uncontrolled diabetes for a very long time, you would reduce your overall incidence of retinopathy, hopefully. But in the acute phase, we do have this risk of bleeding complications with diabetic retinopathy. So we do have to be very, very careful with the initiation and monitoring of these medications. So that was all my slides. So I'm going to hand it back.
Thank you so much. That was a fascinating overview, very comprehensive. And now, Dr. Aminian, can you give us your presentation on cardiovascular risk reduction following bariatric surgery?
Yeah, very good. Hi, everybody. Can you see my slide?
Yes.
Okay. Thanks, Marina and Samer, for the invitation. So in the next 15 minutes, I'm going to talk about cardiovascular risk reduction following bariatric surgery. So here is my disclosure. Some of these companies supported our previous studies, and I appreciate them. So let's briefly talk about the look ahead. You probably know about look ahead. Look ahead, supported by the NIH, 5,000 patients with obesity and diabetes were randomized to receive intensive lifestyle intervention versus usual care. And they were followed over the course of 10 years to study the impact of intensive lifestyle intervention on risk of cardiovascular disease. So you see here in the first year with intensive lifestyle intervention, people in the intervention group lost about 8 kilograms. So baseline weight was about 100 kilograms in both groups. But not surprisingly, some patient gain weight over the course of follow-up, over the course of 10 years. But the difference at 10 years was about 4 kilograms between the two groups. So the other plot shows the trend in the HbA1c, which followed the weight trend. So that 4 kilogram weight difference at the end of the follow-up led to this. There was no significant improvement in reduction in risk of heart attack, stroke, or death in the lifestyle intervention group. So complete overlapping of the care. So that was a negative study. And then the investigators did a subgroup analysis, and they showed that achievement of 10% weight loss in a subgroup of people who lost greater than 10% of their weight loss, they could reduce the risk of cardiovascular disease by 20%. But in the whole cohort, that 4 kilogram weight loss difference, weight difference at the end of trial was not strong enough. So the SELECT trial that most people on the call know about it. So that was a large study supported by Novo Nordisk. So almost 19,000 patients with obesity were randomized, and history of cardiovascular disease were randomized to two groups. One group received semaglutide, the other group received placebo, and they were followed over the course of 4 to 5 years. So as you see with semaglutide, people lost good amount of weight, about 9 kilogram weight loss, and that was maintained over the course of the study. So that 9 kilogram difference led to a significant improvement in risk of, or reduction in risk of cardiovascular disease by 20%. But as you see here, the difference is very small. So you need a magnifying glass to see the difference. So if you plot that on a scale of y-axis from 0 to 100, it's just hard to see it. But then when you increase the scale, then you see the difference. So 20% risk reduction with semaglutide after achieving 9 kilogram weight loss. So we do much better with bariatric surgery. So here is the gastric bypass data, 12-year data, 35 kilogram or 45 kilogram weight reduction with gastric bypass at 2 years, 35 kilogram durability at 12 years. You see the durability of the results. It's the RCT, 37 kilogram weight loss with the bypass, 42 kilogram weight loss with the BPD. So durability of the result is very important. So why am I showing this? Because we have that concept of dose-dependent response. The more the weight loss, the better the outcome. So we have the dose-dependent response for MACE. So people after gastric bypass lose more weight than the gastric sleeve. And that's why the risk of having MACE is smaller with the gastric bypass than the sleeve. So we have dose-dependent response for the cancer. So the greater the weight reduction after bariatric surgery is associated with larger risk reduction with cancer risk. We have dose-dependent response with MASH. So people who lose more weight with bariatric surgery compared with people who lose less weight with bariatric surgery have a smaller chance of progression of their MASH. So that's why bariatric surgery is very, very important because that provides, compare at least to the medication that are available now, provide a much greater weight loss. So let's look at, so the topic of this presentation specifically on cardiovascular risk reduction. So let's look at the impact of surgery on the cardiovascular risk. So here's our data in a population of people who had diabetes, had treatment at the clinic, Cleveland Clinic for past 2 decades. So obviously, surgical patient compared to patient who receive usual care for their obesity and diabetes needed less diabetes medications, including insulin. They needed less medication to control their blood pressure, to control their cholesterol, and you see the durability of the effect over the course of 8 years. So all-cause mortality. So you see here, surgery was associated with 41% reduction in risk of all-cause mortality. So over the course of 8 years, 10% in the surgical group died versus almost 18% in the non-surgical control. So in the beginning, I mean, the first few days, first few weeks, we have that immediate risk after bariatric surgery, which is troublesome, and nobody wants that, nobody likes that. But if we follow the patients over the course of years, we see that surgery outperforms the usual care. So same thing with heart failure. So impact of surgery on the incidence of heart failure was profound. So 62% lowering the risk of heart failure. Again, in the first few days, first few weeks, there is immediate risk for all these cardiovascular outcomes after surgery. But when in the long run, when you follow the patients, then you see that the surgery outperforms the medications. So 31% lowering risk of coronary artery disease, 33% lowering risk of stroke, impact on nephropathy was huge, 60% protection against nephropathy, atrial fibrillation, 22% favoring bariatric surgery. So that was in diabetic population. So we showed that in different population, people who had a sleep apnea. So surgery was associated with 42% lowering risk of MACE. There is no other proven treatment in people with obstructive sleep apnea that could or can reduce the risk of MACE. Again, the first few days, first few weeks, if you look at the beginning of these plots, always you see that some complication, immediate complication with bariatric surgery. So we appreciate that. We don't want that. People don't want that. But in long run, we see the benefit. So how about in people with MASH? So you know that people with fatty liver disease, they usually don't die from their liver disease. They usually die from cardiovascular disease. Again, in the Splendor study, we showed that people who had MASH, biopsy-proven MASH, and had metabolic surgery, they could reduce the risk of MACE, heart attack, stroke, and death by 70% over the course of 10 years. How about in people with obesity without diabetes? The same findings. So it shows that in different populations, regardless of having diabetes or not, sleep apnea or not, fatty liver disease or not, so that impact of weight loss is profound and can protect patients from getting cardiovascular disease and improve survival. So this table shows that in people with obesity, severe obesity, class 3 BMI over 30, their life expectancy is about 8 to 9 years less compared with people with normal BMI. So about 8 to 9 years, they live shorter. So let's see how bariatric surgery can help these people. So here is the meta-analysis of all the studies that compare bariatric surgery versus usual care, published in Lancet. It was not published in SWORD or obesity surgery. It was published in Lancet, the best medical journal. So here you see that about 65,000 patients underwent bariatric surgery versus over 100,000 patients received usual care. So over the course of 30 years, so surgery was associated with 50%, almost 50% lowering risk of dying compared with the usual care. The median life expectancy gain after surgery in the whole cohort was 6 years. In people with diabetes, 9 years, without diabetes with 5 years. So I'm going, after this presentation, I'm going to the OR. I have 2 gastric bypasses. One patient had diabetes and one don't, one doesn't. So in that patient with diabetes, I give her something very powerful that helped her to live 9 years longer. And in that, the other patient, my second case, who doesn't have diabetes, I'm going to give her something, a powerful tool that can help her to live 5 years longer. So that's the impact of the surgery. So you give them something that can help them, on average, live 6 years longer. So no other treatment can provide that impact. So these days, all the talks are about comparing surgery versus the GLP-1s. I just wanted to briefly show that. So let's look at visually, look at the gap between the SELECT trial, semaglutide that I showed, versus the gap here that bariatric surgery can provide. So I understand that the y-scale is different this is from 0 to 100, this is from 0 to 50. But again, if you look at the gap, you see the difference and you appreciate that how impactful bariatric surgery is. So based on the SELECT trial, the relative risk reduction with semaglutide to lower the risk of MACE is about 20% with bariatric surgery. Totality of data show 40 to 50% relative risk reduction. Relative risk reduction is not that important. The absolute risk reduction is more meaningful in this setting. So 1.5% risk reduction with semaglutide versus about 10% after bariatric surgery to lower the risk of MACE. So based on that, number needed to treat to prevent one MACE over the course of 4 or 5 years is about 66 patients. So we need to treat 66 patients with semaglutide to prevent one MACE, but we can achieve that by doing surgery in 10 to 15 patients to prevent one MACE. So medications are getting better, going to get more affordable, cheaper, all great. But if you look at the cost in 2025 to prevent one MACE event, we need to spend to treat those 66 patients for 4 to 5 years. We need to spend $3 million. So if you want to treat 10 to 15 patients with bariatric surgery, we assume the cost of surgery is about $30,000 at the Cleveland Clinic, which is a very expensive place to have bariatric surgery. So it would cost about $300,000. So now you have $3 million. With that $3 million, you want to spend it to save one life, or you want to save 10 lives. So that's the question. So obviously the medication going to be cheaper, more effective over time, but that's the data that we have in 2025. So the FLOW trial, very similar finding in people who had CKD. So they received semaglutide versus placebo, about 3,500 patients who were randomized. Over the course of 4 years, there was 4 kilogram difference between the two groups. So again, you see that there was a difference. So 24% risk reduction in progression of the CKD to end-stage renal disease or dying from renal disease. But curves are very close. So again, you compare that with the impact of bariatric surgery. So you see the gap is much larger when you follow the patient. So again, there is immediate risk after surgery the first few months, but worsening of the kidney function, dehydration, all those kind of stuff. But when you follow the patient over the course of the years, you see the impact of the surgery. So obviously some patients, even the SELECT FLOW, when the medication was free and available to all patients, and they were encouraged to receive free medication, access was not an issue. 27% of patients stopped taking medications for side effects. They didn't like it. They get tired of that. So some patients don't like to take the medication, even free medications. And in real life, that percentage is much larger. So less than half of the patients stay on GLP-1 at 1 year in the real life setting. So indications of bariatric surgery in people with BMI over 35, I think the main indication is patient preference. Surgery is an evidence-based, medications is an evidence-based treatment. So patient should have option to choose between the two. So that's the main concept here. And then if patients don't respond to the AOM, intolerance, contraindications, high cost, access issue, then the surgery would be a good option. Also, people who have more severe disease, people who have multiple comorbidities, higher BMI. So those people need to lose more weight, because show that the greater the weight loss, the better the outcome. Those patients also need to be prioritized to get bariatric surgery. So in summary, surgical community welcomes the introduction of effective anti-obesity medications. Losing large amount of weight by metabolic surgery, by medications, by combination, anyway, can prevent or reverse health consequences of obesity, including severe risk. Bariatric surgery is durable with large magnitude of effect. We have dose response gradient between weight loss and outcomes, and that's why bariatric surgery is still very relevant and gonna stay relevant, because that provides a very large durable effects or weight loss over the course of 10, 15, 20 years. And patients and providers should have the choice to choose between the anti-obesity medications, metabolic surgery, or combination therapy. Thank you very much.
Wow, Ali, what a masterful presentation, and what a convincing argument for the benefits of bariatric surgery, even when we have valid alternatives, so to speak. So you made a point about the dose-dependent response that's being observed in metabolic surgery. Dr. Potluri, do you see the same dose-dependent response with medications? Because I know typically we start with a small dose and then we escalate over time. Or do you reach a bell curve where giving more weight, higher doses doesn't really, or plateaus, or tell me about that.
I think in general, we do see a market dose dependent response. I think that it really depends. Again, it's on the individual. So some people actually never need the highest dose that's available to achieve their weight loss goals, but that's usually not the case for patients with the highest BMIs. Usually we end up actually having very poor responses to the lowest doses in the sense that there's no benefits, right? We're actually just trying to improve tolerance to the medication. And in those with the strongest, highest BMIs, the worst metabolic syndrome, the worst metabolic derangements, that's kind of how I like to view it. Those patients need the highest doses, and we do see a dose-dependent response. And we also see plateaus, very commonly. So, of course, these medications are designed to be ramped up every month, but the reality is that people either don't tolerate the ramping up that quickly or don't need it if they're losing excellent weight at a lower dose for a while. But yes, we do see a very much a dose-dependent response to a lot of these things, especially for weight loss, but also for CKD benefits and MASH, resolution and things like that as well.
Thank you. And again, to our viewers, please feel free to type in any questions in the chat box or any comments you might have. Dr. Kurian, any questions?
Well, so, I loved how you did this and talking about the dose dependence. We see that benefit in you're talking about the dose of medication or, the response, right? When we talk about weight loss surgery and look at trajectories, we're going to see different, and even with medical weight loss, you see different trajectories. Some people are what we say super responders, right? So there's always above average, average, and below average trajectory. But when you talk about this effect, it's evident even in like breast cancer. So there was a paper out there looking at the effect of bariatric surgery on breast cancer, and then it also went and looked at who had superior weight loss, and you could see that there was, even with that, a dose-dependent response, right? Even though this was pitted as like sort of GLP-1s versus surgery, it's still, I think everyone here recognizes that it's a continuum of care. And I would like to know how, you, Vani, and then also Ali, both because you, Vani, you work with SAMR, so you're going to be sending patients over to surgery. And then Ali, from your perspective, using the medications either preoperatively or postoperatively. But Vani, why don't we start with you?
I always tell people it's like blood pressure, So, you don't start with one agent, say that didn't work and toss it out, right? So oftentimes when we're working on metabolic syndrome and obesity, you have to stack these things, right? And so the choice of the agent is based on patient characteristics and preferences, right? So I often view weight loss management very, very similarly. But just like with blood pressure, once you get the benefit, you don't stop the blood pressure medicine, right? You have to stay on it. And so that is true with all GLP-1s. The second you come off the medicines, you see marked weight regain. You are committing to probably lifelong therapy. And so I definitely view metabolic surgery to be exactly like that. It's a strong gun, it's a very effective. And oftentimes in my realm, it's convincing the patient about the importance of weight loss and how much better they feel when they lose the weight. But then if we don't lose enough with the agents that we have available or tolerance and etc., we absolutely need something stronger. I mean, and that's where metabolic surgery comes up. And sometimes the amount of weight you're trying to lose to put these conditions into remission is so, it's not achievable with some of the agents that we have.
And Dr. Aminian, oh, sorry.
Oh, no, I just want to make a point though. So these FDA studies, these, clinical studies with the meds were all designed to ramp up to the top dose.
Yes.
So what we, and when you ramp up to the top dose, you're going to see a lot more of the GI side effects. And I think that there was once, Lee Kaplan once said that, when you see the real world effect of like the what I call triple G, which is the retatrutide, like for example, which is going to come out
Yeah.
probably in a year or two. But it's GIP, GLP-1 receptor agonist, as well as glucagon receptor agonist. So it's a little bit more powerful. But when we see real world data, what we're finding is the patients can't go up to the highest dose, so that their weight loss is going to be not the same as the study. And then we may see greater drop off of because of the GI side effects, because we don't know. And I just heard today, I'm at a meeting actually in Madrid, and Jacques Himpens just said that he had a patient that they started on a GLP-1 receptor agonist, that they happened to check calcitonin levels, and she had an ultrasound and she was fine. And this patient actually wasn't at risk, wasn't having a family history, but she developed medullary thyroid cancer. So we're going to actually see some of that happen as well. But this is the first time I've heard of it. And as part of one of my disclosures, I do speak for Novo Nordisk. So it's the first patient that I've heard of that developed it without like a family history, because that's a black box warning. Ali, you should add somewhere that there's no black box warning against surgery, right? Technically, we could find someone who's too high risk or whatever, but anyway, it's a black box warning. You can't give it to anyone with MEN2 or MTC. So I just wanted to share that the studies were all done at the high dose for that. But Ali, from your perspective, incorporating medicines into practice, either pre or post-op, and then consider this, and I'd like to hear everyone's opinion. We've always fought with just getting, those 30% total body weight loss, or 35% with surgery. But if we combine, we can actually make a new paradigm, which is getting patients out of obesity into like an overweight, reliably getting everybody into an overweight category.
Yeah,
Anyway, Ali.
I mean, you ask very important questions and raise important points, Marina. So, obviously, for everybody, for all patients, providers, so they offer or they start with lifestyle intervention. Unfortunately, it doesn't work for most people. It works. If that works, that's great. But if it doesn't, the point is that we shouldn't stop there. So that's the problem. So patients see the PCP, they ask the patient to eat healthy, exercise more, change their lifestyle, try to empower them. Patient come back next month, they don't lose weight. The same conversation. Patient come back the next month, they don't lose weight, the same conversation. They move forward to the next step. So that's the problem. But we need to move forward if they don't respond, if the patient doesn't respond. And then if we move forward, then we have surgery and the AOMs. They are at the level like this. AOM is not on top of bariatric surgery. Both of them are evidence-based treatment. Some patients get scared of the surgery. They don't like surgery. They have a family member who has surgery, had complications. They just don't like the surgery. Nobody likes the surgery. I don't like the surgery. But some patients at the same time, they don't like the shots. They don't like get the weekly shots for the rest of their life. They just want to undergo an hour surgery and take care of their excess weight. So both should be at the same level. So if we start with the weight loss medication, patient doesn't want the surgery. That's going to be the most common scenario. If they don't want the surgery at the beginning, we start with the AOM. Majority going to respond. That's great. But there are patients who don't respond. They don't tolerate. They can't afford. They have some side effects. They don't lose that much weight that they hope for. So then surgery still can provide hope for those patients. So the problem is that we start with the AOM and then we stuck there. We don't move forward. We forget the option of the surgery. So I think that's the missing part. And if you start with the AOM, if for any reason patient doesn't see the effect that they hope for, side effect, cost, whatever, then we should talk about bariatric surgery. And the same thing with bariatric surgery. Not all patients are successful. Not all patients are going to lose 35% of their body weight. There are patients who lose only 5% or 10% or 15%, or there are patients who gain weight. So those patients also going to benefit from the AOM. As you mentioned, Marina, so that combination going to help. many people if we practice that way. But the problem is that if patients knock obesity medicine door, they're probably going to be on the AOM for the rest of their life. If they knock Dr. Matter's door office or my office, they're going to have surgery. And then if they don't respond, we're going to offer the second surgery and third surgery and fourth surgery. So that shouldn't be the practice. So I think that the best way to practice is to, as you mentioned, to have all available tools, all tools available, and offer them to the patient, to appropriate patient. And for the most part, because we are dealing with a chronic disease, for most patients going to be a combination therapy, combination of lifestyle, medication, and surgery with different orders over the course of patient life.
I think
Thank you,
also,
Ali.
you know, Ali, you said something. I'm sorry, Sam. I just want to say,
Yeah,
you said
yeah,
you want to give the patients all the tools, right?
yeah.
I think in a way, the only time that we're talking about giving a patient a tool is when we're talking about obesity. When we talk about cardiac disease, you know, and we're giving them a medication, we're giving them treatments. And I think that we need to get this focus off of us talking about tools because it's really treatment. And I think that the patients who are coming for the treatment of obesity has increased, and we have to thank social media for that. Get for all the celebrities being on the GLP-1s, but it's getting people to recognize that they're having a disease and going for treatment. You know, so this is, if we need to ourselves stop saying the word tool. Sam, are you
You're
going to say something?
you're absolutely right, Marina.
Absolutely. So three things we've established. One, it's a chronic disease, metabolic syndrome or obesity. Two, the treatments work, especially with GLP-1s, as long as the patient takes them, and that they are dose dependent. I think both of the presenters today established that. So one thing I tell patients is if you come to surgery, I'll give you a lifetime supply of GLP-1, and you won't have to worry about getting shots unless you need them. So I think that helps drive the conversation a little bit with both the referring providers and patients. Sarcopenia, I'd like to talk a little bit about sarcopenia because it's an emerging concern. And we're doing body composition analysis routinely on all our patients, both surgical and medical weight loss patients. And we find that there's a definite element of that happens down the road. My question is regarding the heart muscles. Maybe you could inform us a little bit. When patients lose muscle mass, skeletal muscle, does it also affect cardiac muscle? In other words, is there eventually patients who are getting GLP-1s and losing weight, is there a risk that the benefits, the MACE benefits that are witnessed might actually deteriorate over time because of that?
Yeah, that Bonnie, this is and Ali, this is a great question. So, that there's something out there that said that there is a problem with the heart muscle, right? And that's not being really focused on right now. Obviously, there's cardiac remodeling that goes on with significant weight loss and reduction of inflammatory process in the body. But it's interesting to discuss what happens with the heart muscle, whereas with surgery, there's never been, and I'm not saying surgery versus medicine, right? But in fact, there's not been a worsening of heart failure or any point where weight loss itself was causing a reduction in heart muscle. What are you guys' thoughts?
Rani?
I do think that there is probably a risk, a theoretical risk and probably like a literal risk. The biggest issue, I think, with the GLP-1 receptors and dual incretins is that they cause two big issues, so that kind of work differently. One is that with the decrease of satiety and the decrease of cravings, people don't feel the desire to eat very much. And when they do, they sometimes preferentially choose things that might not be the best for them. They'll say, I want something light, I want something like this, And so I struggle a lot with actually protein malnutrition in my GLP patients who are on aggressive dosing. So I have people who are very happy with the weight loss, but then I check their metabolic panel and I'm like, why is your albumin low? Like, why are you malnourished? Like, what are we doing right now? And so those patients, I actually halt escalation. And in some rare cases, I've had to de-escalate because we're not trying to go into kwashiorkors or do something weird like this,
Mhm.
So that is an implication. And I don't, with the studies, we are seeing that there is a potential risk that if we don't prioritize nutrition, and we can get into trouble there. The second component is the physiologic effect of GLP-1s. We know GLP-1s increase heart rate, and we see this very clearly. Like people who have Apple Watches and things like that, they will say, oh my gosh, my heart rate has gone up by 10 points or 15 points on average, and this is completely new right after the medicine. Increased heart rates have implications. And so we do see there's a reason we put our cardiovascular patients on beta blockers. We're trying to reduce the heart rate so that we can protect the heart and prevent it from overworking. So I suspect that there are those concerns for multiple reasons. And it probably is maybe through those two pathways, but there might be other direct pathways in which GLP-1s might be a little bit dangerous in certain settings to the heart.
Ali, have we witnessed this phenomenon in surgery patients?
No, I mean, basically, people with obesity, Sammy, for the most part, they have cardiomegaly, and they may have diastolic dysfunction, heart failure with preserved ejection fraction. They have enlarged heart, and then losing weight and improving inflammation and the cardiac remodeling and all those changes in body usually are protective, because then the thickness of the ventricle septum, all those going to decrease, and usually heart gets back to its normal size and structure and function. So that's usually the way that it works, and it's protective. I don't know about if too much weight loss or too much improvement is going to work like a double-bladed sword and make it worse in long run. So there is no
But
data.
I think this all underscores the importance of multidisciplinary support for the patients, making sure that they receive adequate nutrition and, of course, physical activities.
But
We're nearing-
sarcopenia is important, Samer, that you mentioned, because I mean data is there showing that about 15 to 20% of weight that people lose with GLP-1s come from muscle loss.
Yeah.
And probably
and when
less
they
degree
regain
with the,
and when they regain weight, it's pure fat.
yes, because when
So
they stop the
actually
medication,
deteriorate.
yeah, when you stop the medication and people start gaining weight, they don't grow muscle, they grow
Yeah.
fat. So
Exactly.
then at the end, 1 year, 2 years after stopping the medication, they're gonna have much worse body composition. They're gonna have, because that 20% of muscle that they've lost going to be replaced by fat, so the body composition going to be worse. So the same thing probably going to happen with bariatric surgery, but we don't have that rate of fast weight regain with bariatric surgery. So it takes over years, give them patients some time to build the muscle. But with the medications, they gain weight all the way back immediately, a few
Yes.
months, and they accumulate a lot of fat, and that worsens their body composition.
We have a comment in the chat box about the Look Ahead trial, and that it was a flawed study. Of course, we know that, but it was the standard at the time. It was a pioneering study. And then Dr. Jaime Ponce, former president of ASMBS, is asking, do you know if there will be more studies that address combination therapy? Both Ali and Vani. And before we wrap up.
I mean, there are two studies in the bariatric surgery field. One is Gravitas, the other one Bari-Optima, is a patient who had bariatric surgery. One is in people with diabetes, the other one for obesity population. They didn't lose that much weight. They were put both studies on liraglutide and then lost good amount of weight. So those are small RCTs. There are several observational studies showing that combination therapy with different orders, medication, then surgery, surgery, then medication, gonna help people. But yes, obviously, we need to do more studies showing the benefit of that approach.
Thank you. Marina?
I think, listen, this has been a great session. I want to thank both of you, really stellar presentations, and thank the audience for their engagement as well. This webinar will obviously live on because you can watch it again, and we'll send out an email about it as well, I'm sure. And it can be seen both on ASMBS site and the IFSO site, I believe. So going forward. And Vani, thank you so much for joining us. And Ali, as always, it was a great presentation. I already screenshotted one of your slides, so I might need the top.
Screenshot
Me too,
two
me too.
slides.
I mean, for all people on the audience, if you want my slide, just send me an email. I can email you the slide
Oh,
deck.
that's very generous of you. All right, thank you all very much, and thank you to James Osterhout for the technical skills in delivering this. And until our next webinar, thank you so much. Bye-bye, everyone.
Thanks, everybody.
Bye, everyone. Thank you.